So I'm excited to introduce our speaker today, Dr. Jeff Quinlan. Dr. Quinlan comes to Iowa after completing a long-standing career in the United States Navy. He earned a Bachelor of Science in Biochemistry and Chemistry from the University of Pittsburgh. He earned his Doctor of Medicine from the University of Pittsburgh School of Medicine and completed family medicine training at the Naval Hospital in Charleston, South Carolina, and in Camp Pendleton, California. He completed a maternity care fellowship at Florida Hospital in Orlando, Florida. And Dr. Quillen is currently the professor and chair and department executive officer of family and community medicine at the University of Iowa Carver College of Medicine. His professional and research interests include women's health, maternity care, obesity, and telemedicine. So thank you so much for being here today, Dr. Quinlan, and I'm going to go ahead and hand it over to you.
Great. Well, thanks very much. Oh, it's great to be here with everybody this afternoon to talk about this important topic. And as you already heard, if you have questions as we're moving through, please make sure that you raise your hand and or drop a question in the chat because we'd love to be able to answer those as we're able. Uh, Also, as you heard, I have a fair number of slides. We'll move through those relatively quickly. This is a topic that could really take 4 to 6 hours to discuss all the components of it, but we'll try to hit some of the highlights today. In particular, we're going to talk a little bit about the different types of diabetes that we see in pregnancy and a little bit about the prevalence of those. Talk about, in particular, risk factors for gestational diabetes, understand the complications both to the pregnant patient and to the developing fetus from gestational diabetes, talk a little bit about how we screen for diabetes and what's recommended and what our options are. And then finally, we'll dive a little bit into the treatment of gestational diabetes and then finish with just maybe a minute or two on how to take care of patients who had gestational diabetes after they deliver. So gestational diabetes develops because as the pregnant patient, the gestation goes on, there's increasing carbohydrate or glucose intolerance. And if that intolerance gets to be too much, then ultimately that becomes gestational diabetes. Every woman has some level of this during their pregnancy, and it's just a matter of whether or not it would reach that threshold of becoming gestational diabetes or not. There's typically two subclassifications that we use. A1 gestational diabetes are the patients that are diet controlled and don't require any medications. And then A2 diabetics are those that we end up ultimately needing to start medication for them. Uh, there is some complication in making these diagnoses because there's a fair amount of undiagnosed pre-gestational diabetes, or what we would commonly think of as type 2 diabetes, and that really makes it a little bit more difficult to understand where we are and how to treat. You can see here that the prevalence in the United States of gestational diabetes is, sorry, the prevalence of diabetes in general in pregnancy is about 7% in the United States, and about 86% of those patients have gestational diabetes. You can see that if you look at the rest of the world, we actually do pretty well, which given the level of obesity in the United States is actually a little bit surprising to me. But in other areas, that rate is a little bit higher. There's a number of risk factors that we think about. The highest risk is actually if you had gestational diabetes in a previous pregnancy, you're much more likely to have gestational diabetes in this pregnancy. And then we'll come back to the second risk factor, which is a body mass index of greater than 25. Also increases your risk of gestational diabetes threefold. Important to note that in women of Asian descent, that BMI is actually greater than 23 that we use instead of 25. As I mentioned, there's a number of maternal complications. The first one is that women who have gestational diabetes are 7.5 times more likely to develop type 2 diabetes during the rest of their life. And so there's some specific recommendations for ongoing screening. between every 1 to 3 years for women who had had gestational diabetes during at least one pregnancy. There's also significantly increased risks of gestational hypertension and preeclampsia, and is cesarean delivery as well is more common. Fetal complications, the thing that we think of probably most often is birth trauma and shoulder dystocia. This is often related, but not always, to macrosomia, which is also more common in pregnant in cases where there's gestational diabetes. Uh, in adolescence, those children also, if mom had gestational diabetes, tend to be more overweight. And there's also an increased risk of birth defects as well. There's been studies that show that children born to women with gestational diabetes do have more hyperbilirubinemia, a little bit more hypoglycemia, and there's a slight increased risk of stillbirth in these infants as well. So who do we screen? I think there's a number of screening regimens that are out there. And so the first thing we need to think about is, well, when do we want to do it? And so the U.S. Preventive Services Task Force would provide a B recommendation for screening all asymptomatic pregnant women after 24 weeks. And typically we think of screening them between 24 and 28 weeks for gestational diabetes. Uh, they also looked at the studies that were available to see if there was evidence of screening women who are asymptomatic before 24 weeks, and that evidence is really inconclusive. So right now, they don't have a recommendation for screening women earlier. Um, ACOG, on the other hand, says that actually in a similar way, ACOG would say that there's inconsistent evidence to indicate that there's benefit from screening for gestational diabetes earlier than 24 weeks. However, in women who are at increased risk for pre-existing or pre-gestational diabetes, then screening before 24 weeks probably makes sense. Ideally, you'd want to screen these patients before they become pregnant, so that you're able to get their glucoses under better control and minimize the risk factors that occur during pregnancy with uncontrolled diabetes. So how do you know who to screen? So this is from the recent consensus guidelines and clinical practice update from ACOG, and they would recommend that screening any adult who is overweight or obese. So again, that's a BMI greater than 25 in the vast majority of the population, greater than 23 in Asian Americans, who have at least one of the following risk factors. And I'm not going to go through each of these individually, but I think you see, like, if I think about the population that we see at the University of Iowa, uh, I would say a large percentage of the patients we see fit into this category where they may actually have pre-gestational diabetes. And in our practice, we do end up doing a lot of screening of women in the first trimester when they present, because we're concerned about that risk of pre-gestational diabetes. Is there a benefit of screening patients? Well, there's a number of studies that show that there is. And so if you looked at the entire screening population, in one of the larger studies that was done, you can see that the risk of large for gestational age birth weight, if you screened everybody early, you had about an 11% decrease on average of the rate of that. You also had an 11% on average decrease in the rate of cesarean delivery. If you looked at just the patients who ultimately got diagnosed with diabetes, by diagnosing them earlier in the first trimester, you actually had almost a 50% reduction in large for gestational age birth weight in the diabetic patients, and you had about a 22% decrease in the cesarean delivery rate. And so I think both of those, just in of themselves, really justify that increased uh, importance of looking at these patients early in pregnancy. Who to screen? So there's a number of screening regimens out there. When I first started training in the 80s and 90s, we did a lot of history-based screening, but studies subsequently showed that if we did history-based screening, that we missed 50% of patients that had gestational diabetes, and so most places don't do that any longer. There's also paradigms out there for risk-based screening. And the hard part is when you look at risk-based, especially as I mentioned previously, with the increasing rates of obesity in the United States, that it only really excludes 10% of women from who you would have screened. And so really the thought is that that's really probably not the bang's not really worth the buck there. And so that's why ACOG, American Diabetic Association, USPSTF all now recommend screening all pregnant women over 24 weeks, and typically, as I mentioned, before 24 and 28 weeks of gestational age. There's also a number of ways to screen. I think largely in the United States, we use the two-step method. The two-step method includes doing a 1 hour, 50-gram oral glucose challenge. And then if that's abnormal, following it up with a 3 hour, 100-gram challenge. And you can see that in studies, they've found that about 15 to 20% of patients will test positive utilizing this method. There's also a one-step method, which employs a 2 hour, 75-gram glucose challenge, and that tends to have lower positive rates, so only about 6% if you use that method. So for the two-step method, that initial 50-gram bolus, you would check the glucose after 1 hour, and there's really three sets of cutoffs that are out there in the literature using 130, 135, or 140. Um, there is no direct comparison randomized control trials to evaluate which of these is the best. If you do use the 140, there's a lower false positive rate, and there's also a better positive predictive value across all races and ethnic groups. If you use a 130 or a 135, the sensitivity marginally improves. Um, I think a number of places find that if you use the 140, it really decreases maternal stress and dissatisfaction because you're going to do fewer 3 hour challenges if you use 140. And so you've got less patients that are going to be initially worried that they have gestational diabetes, frustrated that we made them drink the disgusting uh, glucose solution, and then have to get stuck 4 times for the 3 hour. Um, I think what ACOG would strongly recommend is that within a given institution that you pick one value and everybody uses the same value. And it gets really confusing if that isn't what happens. And so if you're at a place that has, let's say, a midwifery practice, a family medicine practice, and an OB practice, and each of those practices is using a different threshold, then it's going to just cause more problems, more confusion, and lead to increased opportunity to miss patients that probably should be identified. So if you have that positive 1 hour, then you're going to move on to a 100-gram challenge. There's here also two sets of cutoffs you can use. There's the Carpenter and Kustan cutoffs, and then there's also the National Diabetes Data Group cutoff. Um, and so we actually increase the diagnosis by about 50% if we use Carpenter and Kustan. And there's been at least one study that's demonstrated that when you use that screening method or that set of cutoffs, that you actually have a higher rate of you had a higher rate of prenatal complications. And so I think it's better to kind of pick up more people than less people. And so because of that, ACOG would recommend that we use Carpenter and Kustan, and because they're really concerned about potentially missing people who would benefit from treatment. Um, some of the things that we see if we pick up and treat gestational diabetes is There's going to be decreased risk of pregnancy-induced hypertension, shoulder dystocia, cesarean delivery, and macrosomia. And so I think that kind of speaks for itself. I mentioned that there's also the possibility of one-step cutoffs, and this is with that 75-gram load. And so when you do a 75-gram load, you're going to test three separate times. Uh, you're going to do fasting 1 hour and 2 hour. And the cutoffs you can see here are 95, 180, and then 153. Um, and then there's been studies that show that if you have elevated levels on this test, that you definitely have an increased risk of adverse pregnancy outcomes. And so this is an equally reasonable way to test. Kind of looking at, are there benefits to treatment? And so there's a couple studies that I'll point out here. I'll start by saying the answer to that is yes. And so probably the first large study that showed a significant improvement is the 2005 Australian study. And they demonstrated that treatment decreased serious newborn complications from a total of 4% to 1% in patients that had gestational diabetes. And their primary outcomes for that study were perinatal death, shoulder dystocia, and birth trauma. They also demonstrated that there was a decreased risk of preeclampsia, about a 6% decrease, and then about a 9% decrease in large for gestational age infants, and then similarly an 11% decrease in birth weight greater than 4,000 grams. There were a couple things that increased in the treatment group, and so I thought that it'd be important to note those, and that includes the number of infants that were admitted to the nursery increased from 61% to 71%, and their induction rates also increased from 21% to 31%. There's also been one very large multi-center U.S. Randomized controlled trial that failed to demonstrate significant differences in the primary outcomes, which were the same for the Australian trial, but they did demonstrate a decrease in large for gestational age infants, birth weight greater than 4,000 grams, cesarean delivery, shoulder dystocia, and then again the hypertensive disorders. So again, the major studies really do show that treatment is beneficial overall. Once we make the diagnosis, how often do we need to be testing and monitoring glucose in these patients? I would say that ACOG recommends testing 4 times a day. There's not a lot of great evidence that would tell us what the optimal frequency of blood glucose monitoring is. So I think it's reasonable to default to that recommendation of testing 4 times a day. And that would be a fasting, obviously immediately in the morning, and then postprandial. And for postprandial, you can either do a 1 hour postprandial or a 2 hour postprandial. And you can see the cutoffs here. At 1 hour be less than 140, and at 2 hour less than 120. And again, similar to not great evidence to tell us what the frequency should be, there's also not great evidence to tell us whether we should use that 1 hour or 2 hour postprandial. Again, I think it's reasonable to pick a single standard in any given institution, just so that you don't think that somebody doesn't come in and you think that they're talking about 2 hour glucoses and they're really talking about 1 hour or vice versa. Um, I'm not going to go through this whole slide about determining treatment and determining delivery, but we will kind of talk about this in more detail. I really wanted to kind of toss this in so that you, in reviewing after the fact, could have two references that are good for kind of walking you through how to think about that kind of treatment. And so if we make the diagnosis, often the question is, well, do you jump right to medications? And most of the evidence would say that no, similar to what we do often in patients who aren't pregnant, we think about lifestyle changes first. And so the first thing that I would think about doing is kind of addressing nutrition. That typically involves seeing a nutritionist. If you don't have that readily available, it can be a little bit more difficult. But there has been some data that would show that using the nutritionist helps more than just having the provider and clinic staff going over these recommendations. Uh, Carbohydrates should be limited to somewhere between 33 and 40% of the diet. Protein hopefully should be increased in most cases to about 20%. And then you want to keep fat intake at 40% or lower. Additionally, you should recommend exercise. These exercise recommendations are the same for any adult in the United States, which is 30 minutes of moderate intensity exercise, 5 days a week for a total of 150 minutes weekly. So then when should you start medications? Well, there's really no consensus here either. There are a number, or actually two kind of common approaches that I've seen used over the years. One is that if you have two values from the same meal during a week that are elevated greater than 10 milligrams per deciliter above your expected value, so either that 120 or 140, depending upon the timing, or if greater than 20% of all the values for the week are elevated, would be the other time to think about starting treatment. Universally, insulin is considered the gold standard of treatment for gestational diabetes. For patients that kind of have globally elevated values, meaning they're elevated throughout the day and at fasting, recommendations are to start somewhere between zero point 0.7 and 1 unit per kilogram per day. Typically, you're going to give half of that total dose as a long-acting insulin at night, and then the other half is going to be divided into three short-acting pre-meal doses of insulin. And then you would increase that by 10% per week if the glucoses continue to be 20, if 20% of them continue to be above the expected targets. Um, and then if it's just one reading that's consistently elevated, if it's the fasting, you could just think about starting long-acting insulin at night. And if it's just postprandial, then you could think about starting just the short-acting insulin before meals. If you're doing one of those two, you probably don't want to start at the 1 unit per kilogram. You probably want to start at about 50% of that or so. So somewhere between probably a 0.35 and a zero point 0.5 units per kilogram at that point. As far as oral medications are concerned, there's currently no FDA indication for oral treatment in gestational diabetes. And both the American Diabetic Association and ACOG recommend insulin as the first line. The reasons that include things such as that there really is no long-term data to show us the long-term outcomes of having used oral agents. The two most commonly used medications, metformin and glyburide, both cross the placenta. And so there is some concerns about the impact that they may have on the developing fetus. There's been a couple small studies that have associated metformin use with preterm delivery. However, some of the more recent studies have not demonstrated this. And then the other argument would be that about 50% of women will eventually require insulin anyway. And so if you know that about half your patients are going to end up using insulin, why not go more quickly to that so you can get quicker control, better control earlier on? There has been a couple meta-analyses that have looked at trying to determine whether metformin might be superior to insulin, and it has failed to demonstrate any superiority. And so this kind of study really isn't looking to see if they're equivalent or not. It's really trying to determine is metformin better, and it did not show any bet. It did not it wasn't determined to be better for large for gestational age infants, macrosomia, neonatal hypoglycemia, or cesarean delivery when compared to insulin. And it also demonstrated that there was no difference in preterm delivery in using metformin. ACOG does recommend or does say that metformin is a reasonable alternative in women who decline insulin, women who cannot safely administer insulin, or those who cannot afford insulin. Um, and they do also say that if you're thinking about an oral agent, that glyburide should not be used for first-line treatment. If you are going to start metformin, you're going to start with 50 milligrams nightly. Use that for about a week and then go to twice a day. And then you're going to keep titrating up to a maximum of 3 grams per day until you get less than 20% of values being abnormal for the week. Again, I included some information about glyburide in the slide deck. We're not going to cover that because it's not recommended as a first-line treatment in pregnancy. The last thing we'll talk about here quickly is just fetal assessment. Again, this is another area where there's really no consensus on what the optimal approach is. ACOG would recommend that, again, that the specific antepartum testing and frequency of testing should be chosen according to local practice. The data would suggest that for well-controlled A1 gestational diabetics, the testing may not be necessary, and that typically you're going to think about starting testing between 32 and 34 weeks in your A2 diabetics. Again, with those that are kind of poorly controlled, probably at 32, and if you have an A2 that is a little bit better controlled, you may be able to delay till 34 weeks. The recommendation is to no matter how you do this, to measure amniotic fluid on a weekly basis. Again, searching for polyhydramnios here, and then either considering twice weekly NST or a weekly modified biophysical profile. As far as delivery is concerned, optimal delivery timing is unclear. Patients who have good glycemic control, we can do expectant management to at least 39 weeks. And then patients that have poor glycemic control, depending upon how severe that is, considering delivery somewhere between 37 weeks and 38 plus 6 weeks. And then the last thing that we'll just mention here is that if the patient has gestational diabetes and an estimated fetal weight greater than 4,500 grams, the recommendation is to schedule cesarean delivery. And the reason for this is because there is evidence that it decreases the risk of permanent brachial plexus injury. But as you can see, you need to do 588 cesarean deliveries to prevent one case. So it's an awful lot of cesareans to prevent one case of brachial plexus injury. And I think we'll skip postpartum management just in the interest of time, and start to move on to our case presentation. Before we do that, are there any questions or concerns that I can address? All right. Let's go to